of an early results on old data, we would obviously run it again. But our interest is in finding a way to publicly report some of the results from this. And then we can talk about other uses. Pam can share, after we hear from Stacy, Pam can share sort of what they're doing with it in North Carolina through Delays, Blue Cross Blue Shield. And the physicians meeting this morning endorsed moving forward with this. So we're moving forward. So go ahead.
So what I wanted to do is first give you an introduction to the Prometheus model and its methodology. It was built originally as an episode of care bundle payment model, but is being used for that purpose, but also being used currently just the analytics to get at some of the quality and cost metrics to look at provider variation in those. I also want to give you an overview of some of the statewide main results using that data set that was referred to. I'll probably move pretty quickly through this first section so that we can get to the other sections, but stop me with any questions that you have. We'll use that main data to look at some provider level comparisons of the cost and the quality metrics, and I'll tell you what those quality metrics are in a minute. And then also I want to show you some examples of some specialty tiering that is being used in North Carolina. Maybe Pam can speak more to it, using efficiency or cost and quality measures. So what are the Prometheus ECRs? As I mentioned, they were originally developed, they began actually development in 2006 as a bundled payment model around episodes of care that are focused on the patient. So it includes all of the treatment that would be considered to be typical of a particular episode as determined by clinical practice guidelines. We sought a lot of help from the medical community during the process and continue to evolve those metrics. They're time delimited, so they include chronic conditions and they include procedural conditions and inpatient episodes as well. So for chronic conditions, the time period is, what does it take to treat a diabetic patient for a period of 12 months? For a procedural, it's generally a 30-month day look back prior to the procedure and then a 90-day post-discharge date after the procedure. And as I mentioned, they're built, and this is sort of where the key is to use the analytics to look at quality versus cost. They're built to identify typical services, those that would be deemed typical to the particular condition, from services that are associated with potentially avoidable complications, and I'll be referring to them as PACs throughout. Just quickly, I did mention that we did rely on expert opinion throughout the process, starting back in December of 2006, and had various team members, and have since then relied on additional team members for both orthopedic conditions, cardiology conditions, cancer, and then chronic, preventive, and primary care physicians for the chronic diseases. The PACs that we're referring to and the PAC methodology has recently, last year, been endorsed by NQF.
Stacy, I'll just make a comment on cardiology. The last one, Dr. Janet Wright's with the ACC, and she was also involved with the ACC cardiology measure development. So it really is tapping into some of the leading docs nationally.
So just sort of a picture of what the episode looks like. It's made up of, so it contains all of the costs that are relative to the episode. So it'll be the physician's cost, the surgeon's cost, the facility cost. It's the cost of the typical care plus the cost of the potentially avoidable complications. And the typical care costs include the base services that are typical, and then the cost of the severity adjustments, so that you've got the acuity of the particular providers, that you consider the acuity of that provider's patient group. So then if you're looking at differences, whether you're looking at differences across different providers or you're comparing Maine to other states or comparing regions within Maine, the variation in those episode costs then reflect the differences in provider performance in terms of the PACs. So typically higher, generally if there's higher PAC rates, then that results in higher costs. They might also reflect the unit price differentials to the extent that those exist, either across the providers or certainly exist from state to state or even regionally within a state. They'll reflect the severity of the patient, so sicker patients are going to require more resources, utilization of more typical care, but that's controlled for in the analysis. And then provider practice patterns in terms of the frequency and the types of services that they choose to use during the episode compared to other providers. And so what you're left with really is, once you control for the severity, is then really provider performance and prices and practice patterns as being the differentials. So I mentioned currently we have 21 ECRs that we have built. Those 21 ECRs nationally represent about 35% of total commercial insured population. We categorize them into these sort of categories of chronic, acute medical, inpatient procedural, and outpatient procedural. The different time windows are noted here. The ECRs, the individual ECRs we have are in the last column. The ones in red are the ones that I'm going to drill down on a little bit more to give you some examples. Those were chosen in part because the data that we're using is a sample data set from Maine. Eventually it will be much larger. But these in the red had enough volume to make legitimate comparisons at the provider level. Well, the 21 here that are chosen are really sort of the high volume procedures and high cost procedures, and ones that kind of fit well with an episode construction. We are building more episodes. We're looking at whether or not we can build episodes around some of the mental health areas and things like that. But these were initially chosen. The ones in red I chose as examples because they had high enough volume for you. But these really are a mix of kind of higher volume, higher per episode cost, which results in higher total. This is just a snapshot look at that data that was submitted in terms of the 21 episodes. So if you look at the 21 episodes, they represent about $333 million in the data, of which in these categories over here, chronic, inpatient, medical, are really just how we categorize the episodes themselves. So chronic care represents about 56% of the total dollars in that main database. So that is the chronic care episodes. So for diabetes, the 14%, this will include any inpatient stays that might occur for these diabetic patients. It includes all of the services that include for the diabetic patients.
For those in the back, you have full slides in your packet.
Yeah, so you can see probably, and I think you'll need those slides in your packet later for some of the ones that are difficult to see. So for a knee replacement here, for example, that represents 4% of the total dollars. The dollars that are contained in that piece of the pie include the facility costs as well as the physician's costs as well as any post-acute care. So that pie chart just broken up now into bars on total cost, and we can take a look at the split of that cost between what we consider to be the typical services versus the potentially avoidable complications. And the diamonds here just represent the volume. The volume is along the axis to the right of the chart. And you can see the total costs are pretty significant for the chronic conditions. So these are, a function of the volume of the episode plus the cost of the individual episodes. So the chronic conditions are pretty high volume. Some of the other procedural things are much lower volume. The scale's a little off. There's some as low as about 100 episodes. That's as low as it goes. So they, while they're, lower volume, they do have higher episode costs. So they do represent a significant total cost. But you can see the range in PAC rates, and this is the percentage of the dollars that are attributable to potentially avoidable complications. In the red here, ranges anywhere from about 2% for the orthopedic procedures to about 55% CHF, and diabetes has a significant percentage as well, but CHF has that highest percentage. And so what are we talking about when we're talking about these PACs? We look at them and you can see them in the data grouped into 3 different types. A PAC type 1 are those that are related to the index condition, so certain readmissions or A complication related to an implant device, say for a knee surgery, or an exacerbation of an asthma episode. So those are the things kind of best controlled by the treating provider. PAC type 2s are those that might be related to comorbid conditions that might be best controlled by care coordination. So that asthma or exacerbation, say, in a diabetic patient or a knee replacement patient. And PAC type 3 are some of the things that you were looking at earlier. They are the things suggesting patient safety failure, the falls. They include the CMS-defined hospital-acquired conditions as well as the patient safety indicators and things that we consider to be best controlled by process improvement. And you can see the details and how the actual episodes or the PACs fall into each of these categories. So looking at the PAC rates again, which we said range from about 2% of the total dollars or total cost to about 55% of the total cost. This is looking at the main data that we have in that sample data represented by the red bar here, compared to a national reference database that we have that is largely made up of the North and the Southeast, but it is a national database. And you can see that the PAC rates are really lower or similar to that national benchmark for most of the ECRs, though higher for stroke and AMI. So for example, for CHF here, Maine's PAC rate is about 55% compared to about 63 or 64% nationally. We're also showing sort of the minimum that we find in that national database and the maximum that we found in that database. Can also look at how that Maine data compared to the national benchmark based on costs. Here we're looking at the total costs. The costs here are payments that are actually made for the services, and again they include both the typical payments as well as the payments that might have gone for potentially avoidable complications. Here we're just looking at the chronic ECRs, and you can see on the cost basis the average costs are similar to the benchmark again for most of the chronic ECRs, higher for CHF and diabetes. You remember the PAC rate in Maine was lower compared to the benchmark for CHF, yet the average costs here are higher, so it's not a result of having more PACs, but might reflect the cost of the typical services. Remember, we're not controlling for prices here, so it might be a price differential as well. And looking at the same measure, the average cost this time for the procedurals and the inpatient medical episodes, again you see that they're pretty similar to the benchmark for most of these episodes, but higher for stroke, CABG, and PCI. No, the data does not control for price. You can see in the analytics, you can use some measures that control for price, and we haven't done it here. But you can do that. So if price proves to be an important factor in the provider level comparisons, then you probably do want to look at that and control for that. These examples do not. And it's not controlled for these benchmark comparisons either. This website here, this first one, HCI3, that's the Healthcare Incentives Improvement website. If you go on there and follow sort of the Prometheus paths all the way down, all of this information is very transparent. So for example, you would be able to see on there how the episodes come together, what services are determined to be included, what services would be excluded from an episode, and then what of those services would be determined to be typical versus PACs of those episodes. So a lot of information up on that website that you can kind of go through.